The Norwegian part of this project took place in Oslo, our capital, and we named our project First Oslo. In my part of our presentation, I'll first tell you a few facts about the Norwegian healthcare system, as it is somewhat different from your system. I'll present our implementation story, how it all started, and how we went about with our facilitators, barriers, and implementation strategies. Then our results in terms of stepping and patient outcomes, and finally summarize with lessons learned. The organization of the Norwegian healthcare system seeks to support the vision to provide equal and free access for all to high-quality healthcare services. It is mainly publicly, governmentally founded, with a very low share of private provision and also general reluctance to further privatization of healthcare. There are two main authority levels within healthcare. The specialist level service is provided by 4 regional health authorities that you see on the map. They oversee public hospitals. Oslo is in the southeastern region with many hospitals, as 55% of Norway's population lives in this region. A primary level service is organized within municipalities, of which there are 356. They provide primary healthcare, social services, care services, and rehabilitation. So rehabilitation is offered at both levels. Norway has about 15,000 cases of stroke annually, and more than 90% are treated in a specialist stroke unit in a hospital in the acute phase. For subacute and chronic phases, the practice is more differentiated. Some are referred to a rehab unit in a hospital first, whereas others are referred to primary level services directly from the acute stroke unit. The criteria for referring to the various levels are not entirely straightforward, but patients shall require several different rehabilitation professions to get rehabilitation in specialist healthcare, which is not always available in the primary health service. And in addition to the 2 mentioned levels, there are also national and regional competence centra within this publicly founded system. The centers work with targeted research, knowledge management, implementation, teaching, guidance, and other quality promoting work. And they should also provide knowledge support to policymakers. So back to this specific project. Here we are at Aker campus, located in the middle of Oslo. I represent Oslo University Hospital and our unit for rehabilitation, and we treat about 160 stroke patients yearly, all subacute. At the same campus, Oslo Municipality has their unit for rehabilitation, a primary care service. They treat about 70 stroke patients yearly, both subacute and chronic. And also at Aker campus, a regional competence service, the Regional Center for Knowledge Translation in Rehabilitation, is located. I will refer to this as the KT Center further in this presentation. This service is responsible for proposing, initiating, and coordinating methods and models of quality improvement and knowledge translation in rehabilitation. So these 3 units has an ideal co-location for a project like this: collaboration across service levels and organizations. And then to our implementation story. Once upon a time, in 2014, healthcare professionals from the KT Center got presented to high-intensity gait training for patients after stroke. This led to a conversation about possible research collaboration with Norwegian rehabilitation institutes. At the same time in Norway, at Aker campus, clinicians were treating stroke patients, with good results it seemed. However, some of the PTs wondered if this was good enough, especially with regards to dosing. But the bustle of clinical everyday life made it difficult to set aside time to dig deep enough into this, something I guess is certainly recognizable to many here. So the KT Center people, just back from the States, went to present this possible implementation, research and collaboration idea to a senior PT, whom we also could name an opinion leader among the clinicians. The clinicians were interested, at least some, and at least in some parts of it. You know, the hardcore, high-intensity stuff, as it could fit the clinical concern I just mentioned. This led to a process lasting about a year, where the clinicians discussed the literature and evidence formally and informally, if this could be a way of treating stroke patients at our site. And a long story short here, after being in this process for this year, we, the clinicians together with the management, made a joint resolution to do this, implement high-intensity gait training in our treatment of stroke patients. So then it was just to get going, right? Well, you wish, or at least we did. But then Jenny came along with her knowledge translation plan with hundreds of words and concepts we hardly ever heard of. Knowledge gaps and barriers and KT interventions, you name it. At that point, such a plan sounded like a nightmare that would kill all our enthusiasm and even challenge our independence and professional integrity, which is quite important to Norwegians. Not everything American is good news, you know, or at least we know. Oh well, we came to our senses and agreed to make a project plan and not jump to the hardcore stuff too early. And that turned out to be a very wise decision, because with a KT plan, we were made better aware of our facilitators and barriers to succeed. So let me present what we identified as our facilitators. First, this was an academically well-grounded project. We also developed and used a KT plan with necessary guidance and support from KT experts that ensured thoroughness in all parts of the process. Second, we applied and were granted funding for equipment that would be useful for this project. We also had some funding for a project position and research support, which allowed for higher quality. And third, the management throughout the hierarchy in all involved units supported the decision to implement. So these three facilitators were a good start. But there were definitely barriers too. To implement these new treatment strategies, we saw that our current care delivery model had to be changed in some way. We were concerned the documentation related to the project will steal treatment time we already found short. And in Norway, PTs also do arm-hand training, and the new treatment did not cover this. So to leave this to other professions like the OT would free our time, but it would interfere with the OT's planning, timing, and content of therapy. And even though gadgets and new equipment are cool, they could be a hassle too, when it's just easier to do it like you've always done. The other main barrier was related to knowledge of the new treatment and our current intervention strategy. This new method was somewhat unknown and challenged our old mindset. To introduce something new that breaks with traditional knowledge and old truths combined is not easy, and it's definitely a challenge to get all clinicians aboard with this new mindset. Our current treatment at that point included doing many different interventions in one session, just like the pie charts you've seen. We were already offering gait training as a quite substantial part of our treatment, but not to the degree that this new practice demanded. Another aspect of the new treatment was allowing errors and error augmentation. We had to a certain extent focus on quality of movement, as I presume all PTs have learned in school, and at the same time we challenged our patients, but not to the extent of encouraging errors. So to set aside enough time to immense what was new and how it was done was a big barrier in our busy clinical reality. But there were also strategies to overcome these barriers. Having a KT plan made us more aware of what we could do to overcome this in a systematic way. And I've organized our strategies in 3 categories: reorganizing delivery and content, creating learning collaboratives, and audit and feedback. And I'll now go into each of these and tell you some of what we did. There were many things to reorganize when it came to our delivery of care and its contents. And these strategies target both the barriers I just mentioned. All our PTs did an online course, and a group of us went on a study visit to the US, where we got to see high-intensity gait training delivered at different rehabilitation hospitals. Then we developed a specific protocol adapted to our local context. Arm-hand treatment was left to the OTs to a greater extent, who stepped up to this challenge. We set a specific start date. January 1st, 2018 was the date we started offering this treatment. Starting high-intensity gait training changed the content of our treatment. We stopped offering pre-gait activities, balance training, and strength training, to mention some examples. Instead, we offered variable gait training on the treadmill, overground in the corridor, and in stairs. And that was it. So easy and so hard. For some therapists, it was harder to let go. Others stated that it felt like a simplification, meant in a good way, that gave room to really focus on gait and not rush to get through all the usual intervention in a treatment session. So in summary, we made a conscious choice to start this, and even more important, to stop something else, actually letting it go. The next main category of strategies is creating learning collaboratives. For us, that meant to facilitate formation of groups and foster a collaborative learning environment to improve implementation of this clinical innovation. One strategy to target the need for de-implementation was formal and informal case discussions. To stimulate these discussions, we documented questions and concerns. We discussed patient cases in PT meetings, and sometimes we asked experts on KT and high-intensity gait training beforehand and discussed the response in our meetings. And sometimes we videotaped sessions and discussed it. We developed specific documentation sheets that were meant to help the clinicians document the content of the sessions. These sheets were collected in a paper folder, one for each patient, and were available to all the treating PTs in one particular spot. This made it easier to step in on another patient when needed, as you could easily see what was done the previous session or the previous week's assessment. But maybe even more important, it made it easier to dig deeper into specific concerns arising both formally and informally. During such discussions, typical questions could be, how did you get so much more time in the zone than I did? And why did you choose that specific treatment strategy? Do you have any suggestions for me on how to challenge this and that? We tried as often as we could also to come along on other PT sessions and challenge each other with questions of why this and why not that. I would say that we've always had a good culture of openly sharing and questioning treatment choices. And now also, we experienced a safe environment for asking and to be asked questions. The patient's gait and balance assessments were reported in a weekly team conference, and now this got to be more streamlined and objective than before the implementation. This also gave other professions an insight to what was differently offered in the PT sessions. And last here, the clinicians and the management received monthly newsletters on email to ensure that all involved were informed on all aspects of the project. The third category, audit and feedback, was also a strategy used to target the barrier of current intervention strategy to monitor the content of the therapy. Stepping amounts were audited and the patients were notified weekly about steps during their stay. Therapists were notified weekly too on major changes in steps, both positive and negative, and if incorrect use or non-use of the stopwatch. The therapist otherwise had a complete overview of test results for balance, walking speed and distance each week and presented this to the patient and at the weekly team conference. And one of the specific project positions oversaw the documentation and filled in missing information if possible. So back to our main categories again. As the others here emphasized, barriers were not identified at only one point in time. Coming up with an implementation strategy to one barrier often revealed new barriers previously more hidden. Or new barriers came up because of new equipment and routines, like when we had to ensure wheelchair-friendly access to one of the treadmills that didn't have a ramp, or make sure we had a sufficient stock of AFOs, for instance, or phones available in all treatment rooms, as there were no alarm system that covered some of the rooms we now started to use. So it is true for the Norwegian branch as well. We went back and forth, refining our barriers and strategies more than once. And now to the results. Like the others, we had the same questions driving our interpretation. First, were the two groups similar enough to compare? Our two groups are phase 1, our conventional phase, measured in 2017, and phase 2, after implementation of high-intensity gait training in 2018. As you see from the p-values, the patients in the two phases were no different. They were subacute, included about 2 weeks post-stroke, and quite well functioning at admission, indicated by a paretic leg strength of 3 in average. However, the main thing here, the two groups were similar enough to be compared. As I've said, we decided to implement, but did we successfully implement high-intensity gait training? Our fidelity metric was quite simple: increase steps per day. Stepping activity increased with about 1,800 steps per day, from 3,900 to almost 5,800, and we had significant changes in these other stepping metrics too. Monitoring heart rates and rating of preserved exertion was purposely not performed during phase 1 to minimize the PT's desire to change intervention. But during phase 2 we measured, and peak heart rate in PT sessions was in average 79% of heart rate max. The mean heart rate in the session was 66%, and the time in zone was 34% of the therapy session. So in terms of delivering a higher amount of stepping activity, yes, it was implemented successfully. But how did the intervention impact the patients? Did it matter? Here is a figure of changes in gait and balance throughout the length of stay. Self-selected and fastest speed at the top. Bottom left, 6 minutes walk, and bottom right is balance. And the x-axis in all figures is the length of stay. Walking measures first. Blue color is phase 1, usual care, and red is phase 2, high-intensity gait training. And there is a significant between-group differences for all walking measures at week 1 and at discharge. And the changes were also about thresholds considered clinically meaningful. For balance, significant differences were observed at discharge, with no difference at week 1. And the differences between walking measures and balance measures might be due to less focus on variability the first week of the sessions, as it takes some time to get acquainted with the patient's condition and functional level. However, another interesting aspect you can read of this figure is that the results in week 1 of phase 2 are actually similar to week 3 in phase 1. So high-intensity gait training was more efficient and more effective than usual care. So back to the question, yes, it did impact patient outcomes and it did matter to the patients. So what are some of the lessons learned? We learned the importance of having a KT plan, especially when you think you're better off without it, or you think you don't have the time for it. We've seen the importance of asking questions, from the beginning with "could this be different?" to along the way questions like "why not this patient? Why not stairs? Why not faster speed?" Sometimes you get good and important answers to why not, but very often there isn't a good answer and we are challenged to think over all habits. Another important question is also how do you do this and this, and learn from each other and together. And as I said, we had a good culture of asking questions, but this project has emphasized its importance for us. And looking back at our usual care phase, and even before that, we now see the value of measurements differently. We always assessed our patients at admission and discharge, but not weekly. Neither have we analyzed the outcomes in a way that actually influenced decision-making in treatment. As we didn't know our average, let's say, walking speed as an example, looking at research that showed a specific velocity after treatment was not relevant, as we couldn't relate to it. However, now we know what we used to do and how we are doing, and are using it actively in decision-making. And lastly, I would say that being open to ideas and change, as the KT Center people and our PT opinion leader were back then in 2014, became very important. It started with networking and has left us with an even greater network for future projects. So then to summarize our implementation story and results so far. As I just said, it started by networking that presented a possible solution to a present clinical challenge. We had a thorough KT plan and good support. It was successfully implemented as steps increased per session and day, and it impacted patient outcomes. Looking at today, high-intensity gait training is still current treatment in its third year, and new projects are in the planning with long-time follow-up included.